or secondary acquired. It can be primary acquired. It can be congenital, primary acquired. Actually, it can be congenital or acquired. We understand what is acquired. It can be congenital or acquired. And when you see for acquired, this is what it can be congenital. This is one. But the most important, we talked about acquired. Acquired, we talked about perforations. We talked about retraction pockets. We talked about trauma, which makes that skin to go into the wrong space. The wrong space is a skin in the middle ear, a skin which might be in the outer part. Now it goes into the inner part, which is a problem. So now this, whatever brings that skin in the middle ear where it doesn't belong to, this leads to just desquamation of the skin, stagnation of the skin around the mucosa, destruction of the ossicles, and this may be by retraction or by trauma. But what is going to tell us that we are in the cholesteatoma? What is going to tell us that is cholesteatoma? One is location. We talked about location in the pars flaccida. This is one, meaning aticoantral, just in the pars flaccida. The second is the type of otorrhea, the type of pus is the main symptom, because in safe, meaning in the tubotympanic, it is profuse, mucoid, non-fetid, and frequently intermittent. Please, can you please retain this slide? The type of otorrhea, what shows that things is cholesteatoma is the location of perforation in the pars flaccida. This is one. Second is type of discharge. Discharge which is profuse, mucoid, non-fetid, and frequently intermittent in case of safe, if there is no cholesteatoma. If it's just chronic suppurative otitis media, it will be non-profuse, it will be profuse, mucoid, non-fetid, and frequently intermittent. Now, if it's cholesteatoma, the perforation is in pars flaccida and the discharge is scanty, is thick, is scanty, full smelling, more chronic, maybe bloody stained, contains blood. Before it was non-fetid, now is the full smelling, bloody stained, and there are some polyps, some granulation tissues. There are some granulation tissues in the canal or the middle ear. You see what granulation tissues are like other inflammatory tissues, red tissues in the middle ear or the canal. Please take this slide seriously. So the hearing loss is there. This is another symptom. Maybe this is not more important. For me, the cholesteatoma in chronic suppurative otitis media, if it's a cholesteatoma, this slide is quite important. So in chronic suppurative otitis media, we can have hearing loss. We can have otalgia, vertigo, and headache. And this is important. having hearing loss, it's important, it's necessary because there is perforation, the hearing loss is there. But having pain, because normally the chronic suppurative otitis media should not be painful. Having vertigo, having headache, this means that now we are going into complications. So take this slide.
Question.
Yes.
Teacher, I'm not getting what you mean by otolayer. Is it the same as cholesteatoma, or I'm confused?
Otolayer is pus. Otolayer is pus. Otorrhea is pain. Pus in the ear is called otolayer. Right? You understand?
Yes.
Cholesteatoma is the disease, as we said, is skin, desquamated skin in the middle ear, causing recurrent or persistent otolayer. Otolayer is pus discharge. Which kind of discharge do you know?
Purulent.
It can be blood, right?
Mm.
It can be mucus. It can be CSF. CSF is the fluid, is a clear fluid, right? CSF, pus, blood, those are discharge. Now, otolayer is pus discharge. Cholesteatoma is the disease causing persistent pus discharge. Do you understand now?
Yes.
Yeah. So now, to know that you have cholesteatoma, you have to have this characteristic of the blood of the pus discharge. If it's no cholesteatoma, meaning you can have perforation discharge without any issue, just a trauma, and you traumatize yourself and you have perforation in the middle ear. Tympanic membrane is perforated and there is maybe blood infected and there is discharge, then you treat, there is no more discharge and the perforation stays there. But if that pus continues without stopping and despite different kind of treatment measures, now you have to have an idea that this maybe is dangerous. There is a disease which will keep eating bones, eating structures. If we don't remove it, treat it surgically, it will erode even the skull base. It will erode even other structures, injure the nerve, and so on and so forth. So now, these symptoms and signs are characteristic for pus discharge in the case of chronic suppurative otitis media, but in unsafe, which is cholesteatoma, actually unsafe is cholesteatoma. Unsafe means cholesteatoma. So now, in the case of unsafe, these are characteristic of pus. And if on top of this characteristic of pus, there is otolrhea, meaning pain, there is vertigo, there is a headache, you have to know that cholesteatoma, which has been there, eroding bones, causing pus discharge, now is extending to the neighboring structures and maybe has eroded the vestibular system and there is vertigo, maybe has eroded the skull base and there is headache. So those are signs of this pus plus those signs, it means that there is complications. And you have to be very careful. So now let's proceed. Examination, I don't delay on this. You can inspect, you can use otoscope, you can use microscope, you can use suction, you can make culture and sensitivity. This is not important for me. The most important thing is you can investigate by doing audiometry, you can test the hearing, you can do whatever you want, you can do the scans, see the extent of the disease. This is not important for me. What is important is how to manage these chronic suppurative otitis media. So the management consists of medical and surgical. The medical treatment consists of oral toilet, meaning suctioning and washing. Suctioning, you can mop with the cotton swabs. We can make wet irrigation with the normal saline. So all of these are medical management. And after mopping, please take it into this seriously. You can do oral toilet by suctioning, by mopping with the cotton swabs, by irrigation, by irrigating with the normal saline. Sorry. So those are measures that you can use. But remember, please take it suctioning. You can suction, you can irrigate, you can mop, you can suction. All of these are things that you can do to make the oral toilet. And after doing all of this, please put some topical antibiotics. Any topical application means antibiotic topical. Because the chronic suppurative otitis media, antibiotics is not the most important thing. Antibiotic oral, to give oral antibiotics is not important. The important thing is topical mopping and putting topical drops antibiotics or so on and so forth. This is the most important. So this is medical. Now, surgical. Surgical, the aim of surgical is making the ear safe, removing the disease, stopping progression of the disease, and preventing further complications, stopping further discharge. Because seeing someone with the running pus in the outer canal, just on the face, on the neck, it's not important. It's not good. It's better to stop, to do surgery to stop all of this. So this slide is important. The aim of surgical treatment is to remove the cholesteatoma by making the ear safe, is to arrest progression of the disease and complication, is to stop discharge, permanent discharge, and is to stop complications. This is important. So now, for me, this is not important for you. You can know what to do, but what we do for ear surgery are the ones. You can graft the tympanic membrane, the ossicles, remove the retraction pockets, give the hearing aids, ossicular chain reconstruction, do mastoidectomy. Those are the procedures that we can do. This is not important for you. I cannot even ask any question about this, because this is advanced technique for what we can do. But at least know that in case of a cholesteatoma, we do mastoidectomy. We go into the mastoid and remove the disease. Now, you see, The slide that I talked about, those are complications. Complication, this is important. Complication with the middle ear. This is the middle ear. Those are the landmark, the neighboring structures into the anterior. Anteriorly, we can go to the eustachian tube, and posteriorly we go into the mastoid. Medially we go to the inner ear. Superior we go to the middle cranial fossa. Roof floor we go to the vessels. So you see the infection in the mastoid. It can go up into the middle cranial fossa. It can go deep into the inner ear. It can cause abscesses all around. So now, please understand the complication of chronic suppurative otitis media. We will ask you about this in the exams, and we will ask you about this in your rotation. When you do all round on cases, you should be able to know the complications of chronic suppurative otitis media: intracranial, intratemporal, and extratemporal. Please know this. It will come even in the exam. I'm not telling you that it's coming in the next exam, but it may come because this is a crucial slide showing the complications of the chronic suppurative otitis media vis-a-vis the middle ear infection. Any problem about the middle ear infection? Acute otitis media with effusion, and chronic suppurative otitis media, especially complications of chronic suppurative otitis media. So we don't have a lot to talk about the facial nerve. Do you know the facial nerve? Have you learned the facial nerve in the anatomy, right?
Yes.
So what I want to let you know that is the facial nerve passes into the middle ear. So we don't need to go back and know the branches and where it supplies. Do you supposed to know? You're supposed to know. So we don't delay on it. Those are the pathway from the nuclei, from the pons, the leave the brainstem through the cerebropontine junction, go to the geniculate ganglion, internal auditory meatus, and facial nerve, facial canal from the internal auditory meatus to its exit into the stylomastoid foramen. From the internal auditory meatus to the stylomastoid foramen, this is the important part for us, because this is where, as far as the ear is concerned, this is where we meet the facial nerve. Facial nerve, internal auditory meatus, we started with the inner ear. Facial nerve, facial canal, the whole facial canal into the middle ear up to the stylomastoid foramen. This is our part in terms of facial nerve pathway. So this is what I talked. Then just after leaving the stylomastoid foramen, it gives the terminal branches. This is what I don't want to come back to this, right? Because this record what you learned as far as the facial nerve is concerned. Mostly you have to understand that we meet the facial nerve at internal auditory meatus, in the middle ear, and up to the stylom, in the mastoid up to the stylomastoid foramen. The branches I don't care. Yeah, we have time to go through it. So the degree of injury, it may be just part of the nerve, the whole nerve, just the sheath, and so on. This is not necessary for us. And trauma, of course, trauma may be due to surgery, fracture, these other diseases, tumors. It may be idiopathic without any cause. It may be due to systemic disease. So this maybe you can understand what are the causes of nerve disease. Trauma by surgery, trauma by iatrogenic, trauma by fracture, herpes zoster, middle ear infection, middle ear tumors, tumors in the skull base, Bell's palsy without cause, and other systemic disease like leukemia, diabetes, and so on and so forth. Those are the causes of the facial nerve paralysis. So facial nerve paralysis can be treated by decompression if it's compressed by the disease, infection, or tumors. It can anastomose, end-to-end anastomosis, can graft the nerve, can do other plastic procedures. This is not important for us in terms of ear. So what we have to know is more than facial nerve. It's just understand about the facial nerve, understand that we meet the facial nerve from the internal auditory meatus in the middle ear up to the stylomastoid foramen in terms of ear otology. And any infection in the middle ear, any manipulation in the middle ear, any trauma can lead, any fracture can lead to the facial nerve, and we will be obliged to repair by decompressing, by end-to-end anastomosis, by grafting. All of those are possibilities. So what we have to keep in mind, maybe before we close, we finish this otology, is about the diseases of vestibular system, because we say that inner ear also has vestibular disease, vestibular system. The vestibular system causes vertigo or dizziness or disequilibrium. Those are this. One term is vertigo. We call it isereri in Kinyarwanda. So isereri may mean dizziness, vertigo, or disequilibrium. Those are just some terms which are in the same, but which may mean different things. What is for us is that the vertigo may be peripheral or central. It may be caused by a disease in the intracranial cavity or a disease in the vestibular system. The peripheral means vestibular system. So what are the causes of dizziness? What are the causes of ear, nose, and throat causes of dizziness? The ear, nose, and throat causes of dizziness may be infection, head injury, medication, and systemic disease like meningitis. So this is important for me. You can know at least the diseases, the causes, the ENT or vestibular cause of dizziness. On the top, there is ear infection. You can have head injury. You can have some medication causing dizziness and systemic illness like meningitis. Other causes may be systemic, and other diseases like diabetes, like hypocalcemia. You have dehydrated. You have those with the diabetes, when there is hypoglycemia, they maybe have dizziness, but the dizziness from vestibular system is caused by ear infection, head injury, some medication, and systemic causes like meningitis. So someone with non-vestibular causes, there are other non-vestibular causes. We don't need them because this is not our part. But hyperventilation, visual disturbances, decreased blood flow, nervous system disorders, are many. This is not our topic. The most important to know that is There is peripheral, which is vestibular, and non-peripheral. For peripheral, maybe infection, trauma, medication, and infection like meningitis. So there are at least, even if you don't know those disease, if you don't know even those disease, at least know some vestibular disease which may affect, which may cause dizziness. Those are, at least name them. Even if you have time, you can read about them, but those are the 4 diseases which you can have, like ENT origin, and lead to dizziness. Those are called vestibular neuritis. The nerve is affected, is inflamed. This may be benign. This is called benign paroxysmal positional vertigo. One of the disease which is common, it's a vertigo caused by associated with position. It is without any known cause, but you can read, if you have time, you can read on your own. But keep in mind that we have in the vestibular system, we have the common 4 diseases which may lead to vertigo. There is vestibular neuronitis or labyrinthitis. Those are inflammation of the labyrinthine system or inflammation of the nerve, the vestibular nerve. This benign paroxysmal positional vertigo. It's caused by imbalance in the vestibular system. Meniere's disease is the disease caused by hypertension or not hypertension, like too much production of endolymphatic liquid. And now acoustic neuroma is the tumor of the vestibulocochlear nerve. Those are the disease affecting the vestibular system and causing vertigo. If you have time, you can read, you can go through them on your own and read about them, knowing much about them. But at least if we ask you the diseases affecting the vestibular system, there is inflammation of the vestibulocochlear nerve, and especially the superior vestibular nerve. There is inflammation of the labyrinthine system. There is imbalance in the vestibular system, the BPPV, which is positional, and also Meniere's disease, which is a bit much endolymphatic liquid in the vestibular system, and acoustic neuroma, which is the tumor of the nerve. So that's it. That's it in a summary. We can stop there unless there are some questions. Otherwise, the next step, I think we will have a face-to-face teaching, face-to-face sessions. I'm thinking about the second. The second, no, not the second. I want to be in the country. The second will be Sunday. The third, maybe the fourth. Is it possible to schedule a teaching on the 4th, Tuesday 4th?
Yes.
Hello. Hello. We can schedule a session on the 4th during the morning. during the morning we will have the rhinology, the nose and the paranasal sinuses, and during the afternoon we will have the laryngology, right?
Yes.
Yes.
Then we will see how to, maybe if you have questions about this session, this online session, you can ask them on that time before we start with the nose and the paranasal sinuses.
Yes.
So let's schedule the next session on Tuesday 4th. Then we will go through all of this, and maybe in the morning we do one component, in the afternoon we do another one, and finish.
Yeah.
So if any question, please keep somewhere, then we will discuss on that time. Okay. Thank you so much.
Thank you so much too.
Bye. Yeah.